first of all, let me share a storyboard with you. I was with Countess before joining Commission, and I worked with a couple of teams under a 20,000 days campaign umbrella. And one of the teams was very high-intensive user. And I just want to share the storyboard which they bring to the learning session. And I thought it's really funny. And I'm sure you can associate yourself, and you will agree to that storyboard. So let's have a look. I can see the agreements there. And I'm sure the last one you will definitely love. Right, so this is how they share their journey, collaborative journey with the rest of the team. So as we do, let's start with, I know you know this by now, it's by heart, but let's revisit these things. So the framework we are using for this collaborative is Model for Improvement, which consists of 3 questions. What are we trying to accomplish? Where we all got aims and we got charters established. And we have measurement systems there. We have outcome measure, process measure, and balancing measure. So we have the measurement system there. And we have a driver diagram which explains the theory, and we're still refining those driver diagrams with the change ideas. Now, when it comes to PDSA, now, I have to say this is the most important part of this methodology. PDSA is the engine of the whole machine. If there's no PDSA, we are not getting anywhere. Because if there is no, you can have a lot of ideas in your driver diagram, but that doesn't mean anything, right? Because it's theory. Unless you take those ideas and start testing those things and get some learning from it, then only we are getting somewhere. And that applies for opioid as well. So it all depends upon the testing we all are doing, how we're going to come up at the other end with a bundle, right? If there's no testing, as you all know, what will we have at the end of the day, right? So that's PDSA. So, and PDSA is something which is not just used in this testing phase. So where are we at the moment? So we developed a change. We are here. But as we progress further, we're getting into implementation, and then we get into a spread, right? So, and you can see the PDSA continues all throughout the whole, all the steps. So it's not just stopping here. Right? When we get into implementation, we still do testing because we need to do local adaptation, local customization, and how we do it is by testing, right? Taking an idea and testing it again. So PDSA is quite important for the coming months. And so let's revisit PDSA once more, and let's be on the same page with PDSA. So PDSA, Plan, Do, Study, Act. You know, the planning part is, as you all know, this is where we are very clear with what is our change idea, which we're going to test. So is it a sticker we're going to test, or is it a patient information leaflet which we're going to test? So be very clear about that change idea. And then we try to come up with a question so we ask questions so that we can facilitate learning. Right? So we need to ask questions. For example, if it's a sticker, how's the color of the sticker? Is it easy to use? Is it easy to find? All those questions we want to learn from that testing. So you ask questions. And then what you do is you predict. If you're not predicting, that's not a PDSA, right? Because prediction is what helps us to understand the gap between what we think is going to happen versus what actually happens. We think 100% of the nurses will find the sticker absolutely fantastic, but the results would be probably 80%, which means what we identify is the gap in our knowledge, what we think versus what actually is there. So prediction is quite important. So once we got the prediction, we make the plan, who's going to do and when and how. So we make that plan, and then we go out and we do the testing, right? And while doing the testing, we observe and we collect data. Whatever we face, we just record and capture it in your recording. And then we come back to study, and we look at the data, look at the observations and try to study and analyze those. So what did we learn? And we try to compare our predictions against those observations we had and see what we need to do. And then we move into the act part, where we take a decision as a team. Okay, this was the learning. Now where do we go from here? So there are a couple of outcomes from each PDSA. Either you abandon it, saying, no, this is not working, so let's chuck it. Or you say, let's adopt it. It's working. We're confident. Let's adopt it. Or you adapt it. You refine it further, and you test it again. You refine it further. You test it again. So those are the outcomes. And for every PDSA you do, you need to have an outcome. What are you going to do? Adapt, adopt, abandon, or are you going to test in multiple scenario, or are you going to test in a different environment, different ward, right? So that's PDSA in a nutshell. Now, let me share some of the key elements of this PDSA. Now, these are the things which we are talking for the last 3 months, and there are different challenges around these elements, right? So let's go through this list. Scale of test. Nothing can beat a power of 1, right? Start very, very, very small. If you're talking about 5 patients, start with 1. If you're talking about 10 patients, start with 5. Right? Bring it right down, because I can almost guarantee you can learn quite a lot from one person. You don't need to go to 10 patients or 10 person. You can learn. I'm not saying you don't do it, but that's an incremental thing. So start really, really small and make it a quick PDSA. So, and this is the grid, and you will get all this presentation, so you can look at it. So what kind of PDSA you can apply, and that actually depends on the degree of belief. So as you test, your degree of belief will be higher, right? Because you know now what works, what is working, what is not working. So based on that, you increase your testing scale, right? And when you're absolutely sure, when you have strong commitment and high degree, that's where we get into implementation. Right, not before that. If the risk is really high, the cost of failure is high, you don't get into big testing because the cost is too high. Keep it really small. So when you're doing a PDSA, think about these elements. Right? If the cost of failure is too high, keep it really small. Right? So how do you do a testing in a sequential way? Right. So we all got a driver diagram, and we have a change idea in our driver diagram, which is all the theories and assumptions we have. So we take those things, we start testing small scale, right? Small scale testing. And then we do follow-up testing, right? We do more testing. And then once we have a high degree of belief, we go into another environment or condition and test. Test your leaflet in a different ward, which is completely unrelated. Right? Because it's not just about your ward. We're talking about creating a bundle for the whole hospital. Right? Test it with a different ward, different scenario, and also then go wide. Let's try another whole ward or half a ward. So build your knowledge incrementally. So small scale test you will build a lot of knowledge. And by the time you're here, I'll tell you, you have identified all the ways it can fail. You will see multiple PDSAs failing, and failure is not a problem in this case, right? Let's not be predictive about our change ideas, right? It's a theory at the moment, and what we're doing is testing. If it fails, it's absolutely fine, because this is exactly what this methodology is supposed to do. Look at some of the DHPs where we started with an assumption that we got a harm, and we did all the testing, and the data is not supporting us. It's a different thing, right? So this is what's supposed to do. A lot of things will fail. So don't worry about if the testing fails. And we will. The key thing is we'll learn from it. Because when we create bundle and when we want to share with the rest of the countries or different people, yes, we want to tell them how this works, but we also want to tell them how it's not working. We tried this, and these are the ways it doesn't work as well. This is the things we did and failed. So it's very important for us to fail as well. Right. Now, the fate of each PDSA which you carry is different, as you can see. Some of the PDSAs just are not successful, just drop downs. Some of them, where your degree of belief is not high, you need more testing. right? So this is your degree of belief. If you've got average degree of belief, you need to do more testing, right? Your degree of belief is high, you move into implementation, right? And this is, again, supported by evidence as well, or data and evidence. But this is, the key thing is, how confident are you that this is working? This is the solution, and this is working, right? That's the key thing, which testing will help you to gain that confidence. Yes, we have tried this, this is working, right? You know with stamps, you know with stickers, you've tested it, you know how it works now. Right, so one of the key challenge with all of us is documentation, right? And we had this conversation multiple times, how we can capture this. Now, so let me just run through this. So objective, so for example, we want to capture the documentation is our key issue, and that's our objective to improve kind of laxative, capturing the documentation of laxative co-prescribing. Your change idea will be probably a sticker, because there's a specific idea you're trying to test to improve the documentation of laxative, right? Questions. Now, this is where we need to ask a lot of questions so we can learn. So questions, what do you want to learn from this testing? We want to learn that, first of all, does the sticker is doing the thing what we want it to do, which is capturing the laxative or whatever it is. And the other things we want to learn is that, is it easy to use? Do the staff find it easy to use? Is it easy to find the sticker, first of all? So there are so many questions you can put in that box where you want to learn, right? And then what you do is you predict. If it's one patient, you can say, you don't need to use a quantitative number because it's just one patient. But if you're getting into 2 or 3 or 5, you can say, I think 3 out of 5 nurses will probably find the sticker really helpful, or all of them will find it really useful. So that's your prediction based on your experience and your expertise. Right, and then what data you need to learn from it. So it will be survey or asking questions, whatever way you decide. And then you go and decide who's going to do what. Do part, you capture all the observations while you're doing the PDSA. The patient was sleeping, so we couldn't do the audit. So that's a challenge for assessment. And then the study part, we study. What is our prediction, compare our prediction, and see what knowledge we have gained. And then again, as I said, these are the list of things you can do as a next cycle, right? So that's documentation. Now, you can even handwrite and scan it in. It's still okay, because what we don't want to do is spend a lot of time just writing it up. This is not an abstract. This is, if you put 2 sentences, that's enough, right? Just keep it really bullet point for each of those things. Right, so that's documentation. Now, multiple PDSA. Now, this is where I need to go back to the graph which we shared this morning, the average number of PDSAs per team. So the question is, if we have a lot of change ideas in our driver diagram, an average number of PDSA per month is 2. What is the likelihood in the 4 months that we will be testing a lot of ideas in your list? Right. So what we need to think about is that how to do multiple PDSA at the same time. And I'll show you later on how we can put this into practice. But you can do multiple PDSA. So for example, if you have co-prescribing of laxative is one of your driver, there are multiple ways you got multiple ideas how to improve co-prescribing of laxative. One is education, one might be a sticker, one might be a poster. Now, if we go in a sequential way of testing all this, we need more time. Right? This is where we have a team, which is probably 4 or 5 people, and everybody got a capability of carrying 1 PDSA. So easily 4 PDSA is not going anywhere in a week, right? But the average, the numbers at the moment is showing quite low. So that's something for us to think about. So what we do usually is carry out multiple PDSA, and again, it quite depends upon the resourcing you have as well. Right. Now, let me introduce a concept called branching. What is a branching process? Excuse me. The branching process are used to model reproduction, right? So what happens is that you can use this on bacteria and viruses and other things as well. So because everything reproduces itself, it branches out. Now that's exactly what happens with PDSA. So what I mean by that is when you go and do a PDSA and you go and ask questions and learn from it. And then you come back and study it, you have a lot of learning. And what happens is that during that study, you also have identified a lot of other things in the process. Very interesting facts, probably. And there's a tendency to move towards that. Right? Oh, let's do this as well, let's do that as well, right? So what happens is that you are deviating from the main theme of that PDSA. So if sticker was the PDSA, and suddenly you came with the knowledge that, okay, hey, there's something else we can record as well. We can use something. And it's so easy to distract into another learning because you will generate a lot of learning. So you need to be aware that you're still focusing on that one PDSA. So what we need to do is control our branching in some way so that we focus on that one element we are testing. Otherwise, it get bigger and bigger. And I think somebody shared this, probably it's Mid-Central. You had the similar experience where you asked in terms of how we keep a track of this. Because if you're doing 10 PDSA at the same time, how would you keep a track of all this? Multiple learnings and cycles. So this is something which we will be using going forward because to keep it really tight and controlled. So what we use for that is a tool called PDSA Tree. Now this is helpful to keep a track of your PDSA and create a history of your PDSA in a one single pictorial way. So if you look at this, co-prescribe of laxative, that's your driver, right? And then these are the 3 ideas at the moment you have. And you are testing 1, 2, 3, and your outcome is adapt, adapt, adapt. You might abandon, right? And so if you look at poster, you tested, it didn't work. So what you're capturing here is all the PDSAs on one page, and it's showing you a picture, a history of how you're doing a PDSA. Now, I'm going to show you one more slide where I was working with counties, and the project was called Transitions of Care. It looks pretty neat here, but it was much more messier than that. This is the PDSA tree. If you see the red thing, the red circles, these are all the abandoned things which didn't work, right? And it's so easy that you do one PDSA to go into another PDSA from there and lose the whole track of PDSA, what actually we are trying to achieve here. So objective and change idea, you need to keep it connected. If you have a new learning, yes, put it on your tree or draw a diagram, but park it. Otherwise, there'll be an explosion of ideas and an explosion of testing. So as you can see, some of the ideas which work, there's a repeat PDSA, and there's still PDSA going on. So that was around goal discharge stage. So you can see this was all PDSA done on different aspects of the process, right? Just to show you an example. Right, so you have seen all the elements. Now you will think that conceptually it's all good to talk about it. It all makes sense. But how would you put all these elements into practice, real-time practice? So what I'm going to do is it's a very risky step, but I'm just going to attempt this, is to do a real-time PDSA here in this room today. Right? And I'll try to put all those elements together here, and what I encourage you to observe that which all elements I managed to cover. Probably not all, but I'll try to replicate. If I have to do a PDSA, if I'm with a DHP, how would I be doing it? Right? So for that, can I please invite Daniel from Canterbury District Health Board, Danny, and Trevor Cole, please, to come and join me, please. Can we have a mic, please? So I had the opportunity to do a real-time PDSA with Danny when we were in Christchurch with the real patients, and that was really fantastic. It took only 5 minutes, right? And and also Trevor has done a really very smart PDSA in Auckland where he has developed this decision support tool. If that's right to say. And instead of directly going in and applying it in the real-time scenario, he has created a simulation. He has created a scenario to test that tool with doctors, right? So what I'm trying to say is that you don't need a real scenario here. He created a scenario. He tested the tree. He tested the decision support tree. So do you want to introduce yourself?
Hi, my name is Danielle Spencer. I'm a clinical nurse specialist at Christchurch Hospital for general surgery and gastroenterology.
I'm Trevor Coe. I'm the director of the acute pain service at Auckland Hospital.
Great. Thank you both of you. It's really fantastic to have you here and to share this PDSA. So Assume, excuse me, assume this is a team meeting. We three are part of a team, right? And we got multiple ideas. So we got a driver diagram, we got multiple ideas, right? So one of the change idea is patient information leaflet on uncontrolled pain. And then we have also thinking about a decision support tree, right? And the theory behind this patient information is that if we create this information for a welcome pack, that will increase the knowledge and awareness of the patient, right? So that's the theory, what we're thinking. And with decision support tool, I think the theory is that if we can use that, that will help improve our help.
Yeah, it will help improve discharge prescriptions.
Right.
So that they're safer and hopefully reduce harm.
Right. Right, fantastic. So this is the theory behind it, right? And this is, we're testing two tools here. So if we are a team, say we are in a team meeting, it's kind of a bit of a role play, but it's okay. We are in a team meeting, right? And we got two ideas. So what I'm saying, Danny, can you pick up one idea and do, and Trevor, can we pick up one idea so we can distribute the ideas, right? Okay. So what we're going to do is, Danny, let's write up the PDSA quickly, and then what we'll do is we'll find a person in this room who's a real consumer, and we got Chris there as a consumer. We can test our, this is a real time. This is not orchestrated, okay? This is real time. So we'll test that with one patient and see what we can learn, right? And similarly, we have another idea here which we can test, and I have already identified the person because it's a doctor base, so I have to go to Francis to get some feedback on that one that tool, right? So plan part, right? What is the objective here? To increase patient knowledge and awareness on opioid or uncontrolled pain, right? That's our key objective, right? And what is the change idea here? Change idea is our patient information leaflet, or in right? Okay. Right. So what is that we want to learn about this thing? First of all, so I can start like, can patient understand it? Right? What else? What else do you think? Yeah, okay, anything missing? Okay. What else we want to learn from this? Useful, okay. Okay. Okay, what else we want to learn from this one cycle? Is it easy to read? Easy to use? Language? Right? So you can list down a number of questions where you know, whatever you want to learn. So let's make a prediction quickly. What do you think is going to happen? Because it's your tool. What do you think?
I think it will be easy to understand.
So, okay, easy to understand. So, because it's just one patient, you think it will be easy, right? Okay. Okay. And what do you think about other things? Do you think the language will be okay? What's your prediction here?
Yes, I think the language will be.
Right, because one patient is quite easy to just do the prediction. When you have two or more, then that's where you get into quantitative. I think 2 out of 5 will think this way, right? So, and the plan part, the last part of the planning is that who's going to do it. So definitely it's Danny who's going to do it, and doing it now. So that's the planning part done. How much time it took? How much time it took to do the planning part, right? All you need to do is go and do the testing, right? So PDSA 2. Right? So the objective of this is to, so Trevor, with the decision support tool, the objective of this to increase the knowledge and awareness of staff?
This particular PDSA would be to, with Francis, is to check that it's understandable and the logic is correct.
So the tool itself, the purpose of tool is to increase the knowledge and awareness of the doctors?
No, it's to provide a safe.
Okay.
Sorry. The objective of the decision tool is to produce uniform, safe prescriptions of opiates.
Right. And so we got a change idea, which is decision support tool. So what is that we want to learn from this cycle? So you want to test the logic?
Yes.
Is it logical?
Is it logical?
Okay. Anything else we would like to learn from that one testing?
And whether you'd need to do it on a few people to make sure that they all come out with the same answer.
Right.
Otherwise, it's not valid. Yeah, uniform.
So that's kind of multiple things, but you can have a lot of questions. You know what I mean. So, and what is your prediction with Frances? I know you're friends. Probably,
That she'll find it complicated first time round, but with practice, it'll be easy.
And I think that's interesting, your prediction, because prediction doesn't need to be always in a positive way. You know, what he's saying is that she will find it complicated. So that's what he's thinking is going to happen. So we'll figure that out. And the last part is who's going to do what. We already know that, right? So 2 PDSAs, we're just going to run, okay? So do you want to go ahead and, so Chris, can you help us please do this PDSA? And we'll hand out this tool to Chris and Frances.
Can I have it back, Judy, please?
And then we will go back to both these patients in 5 minutes. When you come back after doing a PDSA, there's a lot of knowledge generated, right? And what I've observed is that we get into a meeting and we can talk about it for half an hour or 1 hour about that topic. And the thing is that we don't have that kind of time. If you're doing 10 PDSA, where are you going to find the time from? Right? So this is where rapid cycle comes in. So what we need to do is follow some kind of format, and I'll show you when it comes back. So you can use this format to discuss PDSA in your meeting. So when you are reporting back your PDSA, stick to the key points. Let's not go into the deeper story about it. I know we would like to talk about it, but unfortunately we don't have time. Right? So the objective of PDSA was this. My change idea was the stamp. Right? The question was this. My prediction was this, and this is what we learned. This is what data is showing. Right? And as a team, you take a decision, okay, so what should we do from here? Shall we refine it or shall we abandon it? As a team, you discuss, and then you decide, move on. Right? How much time it will take. So it's about that bringing that discipline into the whole testing, because if you lose that discipline, you're losing time. And if you're losing time, you're losing the ability to test more, right? And this exactly want to show you that we are doing a 2 real PDSA within a span of 10 minutes probably, right? So think about you have a whole week, and it's just asking 1 patient, 2 patient, right? So shall we? Francis is getting really serious about it. Right. Meanwhile, they finish looking at those 2 things. Is there any comments, any questions before we go back to our PDSA? Everybody's clear. That's great. So I know it's not finished, but can we go back to that PDSA and let's ask Chris. So the first question was, can you understand, is it easy to follow and understand?
It would be for me probably, because I've got a bit more knowledge, but I'm looking at it from a health literacy perspective. So we're looking to ensure that anyone with a reading age of up to 12 would understand it. So from that perspective, you can see the things I've changed already. I only got past the first paragraph. It's just the meaning and the language used, I think, which is quite interesting. I don't know what your thoughts on it will be. The questions we wanted to find answers, is that what it...
No, you don't have to follow
I don't
that.
have to do that.
But did you find this information useful as a patient?
Well, I only got past the first paragraph. So...
Right,
But the pictures would be good. But you can see, I like the pictures, but you can see what I've done here. See, the first thing here says, what if I experience pain? So if I've changed that to what if I am in pain? And it says, please let staff know. Well, how do I know who the staff are? So you might have to just put the nurse or something like that, you know, nothing wrong with that. Other words here like, if you have pain during your stay, well, you don't need to have during your stay. Just if you have pain, we will give you medicine to help the pain. We will ask you to score the pain between 0 and 5, that's okay. Before and after, it says treatment. Well, what treatment are we talking about? We're talking about after the medication, isn't it? Or the medicine?
Right.
So just those sorts of things. Hallucinations, I wouldn't understand what that was, you know, if I was a 12-year-old. So just the health literacy side is what I'd focus on.
Right.
Thank you.
No, I think that's fantastic. So, just want to show you that real-time PDSA, which we did in 10 minutes. So, did we learn something from that PDSA, one single patient, one single person? Because the likelihood is that when we go and do 100 patients, that's the same thing which we're going to find. So why to waste all the time when we can learn from one person? And so what we will do is that we'll finish the study and act part, exactly what Chris shared. So all the things which he shared, hallucination, it's not clear. Change the language, it's not clear. Smileys are good. So these are the feedbacks, right? So based on all those feedback, so we'll capture all those in the study and act part, right, what exactly she said. So that's one PDSA. Let's look at what's happened with the second PDSA. Thank you, Trevor. No, do we need to?
Did you find it simple?
Yes. Oh. Sorry.
Liar.
Oh, sorry,
Well,
Danny.
remember, it's what I do every day.
Where are you going?
I would say that it's logical. I don't know if it's repeatable. You'd have to try that on different patients. You manage to cover most of what needs to be covered in a discharge decision tool, reviewing the notes, checking what they're on already, checking if they've been on long-acting, checking if they're on a local anaesthetic block, and simple yes-no decisions. I think it's very logical and well done. I would disagree with one or two of the points, like it's not clear about the decision at the end about prescribing the opioid with half to full dose as a range. I would want that a little bit simplified. The discussion with the acute pain service, discussion with a prescriber. But overall, I think something that appears to be very complicated, that you have to take into account so much, has been beautifully simplified and nicely arranged. So I would try that with a few more people.
Great.
On a house session, yes.
That's really fantastic. See, the thing is, see the power of that one feedback, one testing. We got some ideas from one person that what is working or not working. And what we can do is now go back and re-look into those things. So again, we'll finish the study and act part based on what the feedback which we got, right? And the next question is, so as a team, hey, so I want to show you the last part of it. So then if you want to come here, please. Would you like to share your PDSA based on that format? What we just did, can you share that PDSA based on this format? The one which we did. Yeah.
So the objective.
Yes. So assume this is a team meeting, right? We're all sitting together and everybody's feeding back in terms of this is what I did last week or yesterday, and we're feeding back to each other, right? And see how much time it takes to just feedback.
Okay, so the objective of this PDSA cycle was to develop an insert for our Welcome to the Ward pamphlet. Well, that's kind of the change idea, really, isn't it?
Yeah.
The change idea. The questions that we wanted to find answers to were whether it was easy to understand, whether it flowed, whether Chris thought it might be helpful to have that information as a patient, and looking at the language. And our predictions were wrong. It would be easy to understand and simple. And while doing the PDSA, we discovered that we should always get patient feedback, and that we probably need to put it past our literacy person at work who can help us to simplify the language first and then send it out.
Yeah, so
before
there's
we do
few
it.
changes which he has recommended.
Yeah.
So what are we going to do next? So we're going to adapt,
Yes, we're going to do
refine it,
another
and
PDSA.
do a
once
testing,
we've
right? And
adapted
if you have
it.
to do another PDSA, how much time it will take? We got another customer, Judith here. But what I'm saying is that this is a rapid cycle. So thank you very much, Danny. Thank you, Trevor. Wonderful PDSAs, two great PDSAs, and thank you for helping us understand that. Thank you. So this is frontline in action, right? So let's go back to the elements. Did we cover those elements? Can you do multiple cycles at the same time? Right? You can give it a try. I would say give it a try. Can you do small numbers to start with and learn fast, right? Rather than waiting for 1 week to do one PDSA. Can you do it in a day and move on and try to do, you just need 5-10 minutes. Give a pamphlet and go back next day or something, and you will still learn a lot. So I'll try to put all those elements into that real-time PDSA to show you that can't be done in a rapid pace. So give it when you go back, give it a try. But before we move that, what we're going to do is that we are going to do a PDSA, each one of us, just to go through that exercise again, right? Because this is very important for us, right? So here we go. That's the instructions. So you all have, you got a lot of resources on your board. A lot of resources you got here today. What I will encourage is that to pick up one resource per person. If you don't have, you can pair up. But pick a resource from your own DHB and find a person in this room and go and do a testing. You got a template on your table. Fill those things in. Right? Don't worry about writing big paragraphs, 1 or 2 lines, and go and test and exchange your kind of testing with the other person. So give it a go and see how it goes. And we can give you like 5 minutes, if that's okay. Just pick a resource and just test with someone else. Before going into the break, can I get some initial feedback, and you can continue with your testing. So would you like to share your thoughts in terms of how did that exercise go? Anyone?
Yeah, managing constipation brochure.
So are you saying that, so is a theory that brochure is going to reduce constipation rate? Or is the driver to increase patient knowledge and awareness?
Well, the driver is, or the objective is, via increasing patients' awareness, it will be reflected on the incidence of constipation.
Absolutely.
And how we are doing that is using, the approach is using a brochure.
Right.
There is a lot of approaches. You can use a poster,
Absolutely.
you can have a face-to-face interaction or anything like that, but what we are using is a brochure.
Absolutely. So the driver you're trying to influence is patient knowledge and awareness.
Exactly.
And the way you're trying to do is using that leaflet or pamphlet.
Exactly.
So what you're testing, the specific change idea is that pamphlet or the leaflet here, right? Yes, everything will ultimately impact the constipation rate, but that's your aim, right? Here you're trying to influence the driver, and the driver is knowledge and awareness. So the theory behind that is if we give a leaflet or pamphlet to patient, that will increase their knowledge and awareness, which will in turn reduce the harm, right? So that's one of the testing. So any other feedback? Anyone else would like to share or talk about it? Any experience? Any aha moments? If not, please feel free to continue the PDSA among each other, and it's break time, so tea is served there. Please feel free to continue the testing.